Hello, everyone, and welcome to today's webinar, Integrating Suicide Prevention into the SBIRT Model. I'm Tracy McPherson, and I will be your moderator for today's event. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. I provided my contact information here for your convenience. You're welcome to reach out to me about this webinar or any webinar in our series and about questions related to screening brief intervention. This webinar is produced in partnership with the Adolescent SBIRT Project, NORC at the University of Chicago, and the Brief Intervention Group, or the BIG Initiative, and is sponsored by the Conrad N. Hilton Foundation. We invite you to visit our website at www.sbirt.webs.com or contact our team at sbirtteam@norc.org. Today's webinar is one in a series, so we hope that you will check all of our webinars out. We have a lot of important topics lined up for this webinar series. As you can see, we have a wonderful review of substance use screening tools specifically for adolescents and young adults. We today, of course, are going to be talking about suicide prevention and integration of suicide prevention into the SBIRT model, and we will also be bringing you more webinars around suicide prevention. And we also will be talking about workforce development across the series, looking at primary care professionals and preparing them, building their readiness to integrate adolescent screening and brief intervention into integrated behavioral health, and looking at some results of a national survey around preparedness. And we'll also be looking at health professional training around adolescent SBIRT education, looking at social work, nursing, other disciplines, and interprofessional education, and looking at a national effort to prepare the workforce. We invite you to download this flyer. Also visit the website, the sbirt.webs.com website. You click on webinars. You can also link directly from this slide to that page. There's a full listing there where you can sign up for all the webinars. You can get all of the dates. And we also have individual flyers for each of our webinars. And we invite you to share these with others in your organization, with colleagues, with students. They're open to everyone. They're available free at no cost. And so we invite you to help support our dissemination efforts to really reach as many folks as possible. For reference, you can download the PowerPoint slides and other resources on our website. Each of our webinars will have a dedicated page where all of the PowerPoint and materials will be located. For today's webinar, you can see we have a dedicated page at sbirt.webs.com/suicide-SBIRT. After the webinar concludes, you'll receive a follow-up email from us, and it will contain instructions for watching the on-demand recording available 24 hours a day, 7 days a week. You'll be able to obtain a free certificate of attendance, and we will ask you to complete a very short evaluation survey. Unlike other evaluation surveys you may have completed in the past around training satisfaction, those are very important. But what you'll notice is that we're really trying to better understand your interest in the professional development that we're offering. We're really trying to really provide you over time a lot of good content. So the evaluation is really important to us, and really we look at this to try to inform how we're going to develop professional education in the future. So I can't urge you enough and emphasize enough how important it is to our work. So please complete that and then request your certificate of attendance. If you wish to ask a question, you can do so by typing into the questions pane in the GoToWebinar control panel on your computer or your mobile device. Someone from our team will respond to you as soon as possible after the webinar concludes. Now it's my pleasure to introduce our webinar presenter today, Dr. Brett Harris. Dr. Brett Harris is the Director of Public Health Initiatives at the Suicide Prevention Office of the New York State Office of Mental Health, or OMH. In this role, Dr. Harris works with large health systems and community providers to integrate suicide-safer care into multiple service settings, including inpatient and outpatient mental health, emergency departments, substance use disorder treatment, and primary care. Dr. Harris is also a clinical assistant professor at the University at Albany School of Public Health, where she is designing a course in suicide prevention and collaborating on alcohol and drug prevention and early intervention projects. Prior to joining OMH and the University at Albany, Dr. Harris developed, implemented, and evaluated alcohol and drug screening, brief intervention, and referral to treatment projects with the New York State Office of Alcoholism and Substance Abuse Services, fondly known as OASIS. Dr. Harris received her Doctor and Master of Public Health from the University at Albany and her Bachelor of Science from Cornell University. So I'd like to thank you, Dr. Harris, for sharing with us today your expertise around suicide prevention and the SBIRT model, and I'm going to turn it over to you.
Thank you, Dr. McPherson, and I want to thank everyone for joining the webinar today. As Dr. McPherson was describing my background, I spent about 6 years working in SBIRT. So as I moved about 3 years ago into the suicide prevention field, I naturally saw a bunch of parallels to the SBIRT protocol, and I feel that collaborating between substance use and suicide prevention is the best way to make use of scarce resources, as well as to provide suicide prevention and intervention to a particularly high-risk population that would be those who may be exhibiting problem substance use. So I want to start off with a poll question. What is your primary field? Substance use, suicide prevention, or other? Please complete the poll. Great. Okay. Thank you, everyone, for completing the poll. And so this is helpful to me to direct the presentation. And now to get started. Okay. So as you can see in this slide, we have what we've been calling an opioid epidemic. So you could see the red line, drug overdose has been increasing. I guess steadily, and then even greater starting in 2013, 14, and recently, as compared to other issues that we've historically been addressing in public health and healthcare, so heart disease, cancer, stroke, as well as all-cause mortality. And as we've been talking recently about the opioid epidemic in the last, I would say, 4 or 5 years, this has been constant discussion, at least among public health and healthcare, as well as the substance use field. This has been going on for a while. Now, I added an orange line in there for suicide. So as we've been talking about this rise in drug overdoses, we've also been having a steady rise in suicide over the same time period. Now, it may look like it's a much smaller, I guess, public health issue than drug overdose, but thinking about it from someone that comes from the suicide prevention field, it actually, suicide would probably increase a bit, and if you're looking at intentional drug overdoses, possibly decrease a little bit because of misclassification. It's very difficult to classify suicides as intentional, so sometimes they don't get represented. So we actually, in the suicide prevention field, emphasize that the suicide rates are often underreported. So very recently, and as I was developing the slides for this presentation, the term self-injury mortality has been coming into the forefront. So it's really the issue or the idea of addressing drug overdose and suicide together. So when presenting this as a public health problem, it's the really self-injury mortality rather than in separate kind of separate fields. So there in 2017, the most recent data that's available, there were over 70,000 drug overdoses and 47,000 suicides. And as I was saying, the number of suicides are often underestimated. So, um, just from perspective, in most cases, medical examiners and coroners who are classifying cause of death, they classify drug overdoses as accidental or undetermined unless the decedent has left a suicide note. So the notes that express intent are left in less than one third of cases. So as we have this underestimate, now if we were to group them together as self-injury mortality, we'd have a better picture of what the overall issue is, and just underscoring the fact that these two issues can be addressed together. So looking at it as suicide prevention, as substance use, and opioid overdose prevention. And also keeping in mind that intervention is different for unintentional versus intentional overdoses. So, as we're looking and struggling with ways to combat the opioid epidemic, as we're doing a lot, money is federal funding is being put in. There's a lot of initiatives to distribute naloxone as well as to provide medication-assisted treatment and safely prescribe medication. That actually suicide prevention could be used to prevent opioid overdose. So, it's because this intervention is different depending on whether it's intentional or unintentional. So now that we have a number of people in the substance use field and the SBIRT field that are part of this webinar, I want to really describe suicide as a public health problem. So I'll go into, on the next slides, the demographic groups that it impacts as well as statistical trends. So just recently, in the past, in 2018, the Centers for Disease Control and Prevention released a vital signs report on suicide, and this is from that report, and it's really just highlighting that rates have increased in almost every single state. And the darker, as you can see, the key provides the percent increase, but you can see in the more in like the West and the Midwest, there are greater increases in more the rural areas. Now, so you can see on the pie chart on the right, um, suicide deaths by gender. You could see that suicide disproportionately impacts men. So more than three-quarters of suicide deaths were among men in the U.S. And then when breaking it down again, you can see on the left chart that once again, males are representing the majority of suicides, but there is a variation in age. You can see that it kind of steadily rises up to middle age and then slightly decreases, then greatly increases in the elderly 85 plus population. So just to give you kind of some ideas as to what the impact, to what this means here, is that particularly the 85 plus, more like the suicide attempts become more lethal. So that's the reason for the great increase there. It actually varies by state, and in some states, the greatest proportion of suicides occur among middle-aged men. So that's really a definite focus of suicide prevention is among middle-aged men. So there's a similar pattern among females with the increase at middle age. It's not the same at the elderly, 85 plus. Now the next slide is just highlighting self-harm. So we take this as, in the suicide prevention field, as suicide attempts, but it's also just self-injury behavior and not necessarily an attempt to take one's life. But they're all grouped together, and you can see that it's different than the suicide death rate. So this, I guess, disproportionately impacts women and youth. So youth are more likely to attempt suicide. It's actually a non-lethal attempt, whereas men they actually their attempts are more likely to be lethal. Now, taking a look at this by race and ethnicity, as well as age, I know this is a very busy picture here, but American Indian, Alaska Native, they're definitely disproportionately impacted by suicide. And you can see this is in the younger population, so the 15 to 24, 25 to 34, and it starts to go down a bit, whereas the white population starts increasing and becoming the highest rates of all of the racial ethnic groups. So once again, it, suicide disproportionately impacts white populations, and particularly white middle age. And you can see the difference here again with the American Indian, Alaskan Natives among younger populations. Now, taking a look at means, so the ways that suicide attempts are made, firearms count for about half of suicide deaths. So, firearms are the most lethal method, and this really does depend on what state you're in, but overall in the U.S., firearms is the greatest means by far. Um, I come from the state of New York, and New York firearms are not the greatest means, and this is very likely because of gun control laws. So that, of course, that underscores the importance of that in our political discussion. Suffocation is a little bit more than a quarter, and then poisoning. So there's a little bit what I was just talking about with drug overdoses, intentional versus unintentional. It falls in that category. And then 7.7% other. So that includes things like drowning or jumping from high places like a bridge or building. Then taking a look at gender, again, this is you can look at the firearm part of this graph. You can see that men are much more likely to take their lives by firearm than are women, and this once again accounts for the lethality of the method, showing why men are disproportionately shown in the suicide rates. As I said before, more than 3/4 of suicides are among men. Poisoning is more likely among women, and you can see 31% for women and 9% for men. Suffocation is about even. And so geography plays a very big role in this, so urban versus rural classification. And this is taken from the National Vital Statistics System, and you can see that first of all, it shows the difference between 1999 and 2017, once again increasing, and it increases, the suicide rate increases as you get from a large central metro area to a non-core area, meaning the more rural you get, the higher the rate of suicide. This could be for a number of different reasons, and there's higher firearm ownership, which is a main reason for it. Also, lack of access to services. Breaking it down a little bit more, this is kind of what I was talking about on the last slide. You can see that the rates, again, by urban and rural classification, and firearm suicide rates are much greater in rural areas than urban or suburban areas. Now, breaking this down, so we talked about suicides and suicide attempts. There are also disproportionate, like you increase exponentially the number of people that are impacted when you talk about those who have had thoughts of suicide or seriously considered attempting suicide. So this is a very difficult issue to deal with, and this causes other difficulties, which is, so as you can see, exponentially increasing this issue where it doesn't appear, I guess, on paper when you're looking at the statistics. Among youth, I wanted to point out this is from the Youth Risk Behavior Survey done by the CDC among high school students in the U.S. And I also broke it down by sexual orientation because we always talk about how lesbian, gay, bisexual, and transgender individuals are disproportionately impacted. So I pulled this data to demonstrate this where it's very difficult to obtain information on this population. So this is where we have it. And you can see that, first of all, there's just looking at the total, about 32% have felt sad or hopeless in the past 12 months prior to the survey. We've had 17% that seriously considered attempting suicide, about 14% that had made a suicide plan, and 7.4% that attempted suicide. Now, you can see the green bar, how much greater this is for gay or lesbian individuals. And that is definitely problematic, and states across the nation are trying to make efforts to address this in this population. So, what contributes to suicide? Usually, people talk about depression, so they assume that it's depression that. So, someone has an underlying depression. So, we talk about treating the depression, and then the suicidality will go away. Similar with substance use, so maybe substance use is underlying it. So let's treat the substance use, and the suicidality will go away. However, there are many factors that contribute to suicide, among those with or without a known mental health condition. So maybe uh, a lot of people who take their lives or attempt suicide do have a mental health condition, but a lot of people don't, as we know, don't access services. They may not know that they have this condition and are not being treated. So there are a lot of issues that underlie this, and 42% report relationship problems. 29% had a crisis in the past or upcoming 2 weeks. 22% had a physical health problem. 28% problematic substance use. 16% job or financial problem. 9% criminal legal problem, and 4% loss of housing. So there's a number of things that underlie um, the issue and contribute to suicide. So, something that I've been working on for the last few years is the intersection of substance use and suicide. So you can see that they're rising together. Yes, they are interrelated. For those of you who know all the statistics on drug overdose that I was just presenting on suicide, there are similarities and differences. So, I'm just going to talk briefly about drug overdose, and then kind of where we can move forward from there. So, for once again, the most recent data that's available from 2017, about 68% of drug overdose involved opioids. So between 2016 and 17, we had an increase in overdose deaths involving synthetic opioids that increased at 45%. Um, Also of interest, noted in the data, cocaine-related overdose deaths increased 34%, and psychostimulant-related overdose deaths 33%, and it actually remained stable for prescription opioids and heroin. So of interest is that the authors of the study were kind of underscoring that illicitly manufactured fentanyl was mixed into other drugs, so this is likely contributing to that increase in overdoses. And of importance for this webinar is that injection drug use increases the risk of suicide 14-fold, and that opiates, including heroin and prescription painkillers, are present in 20% of suicide deaths in the U.S. So I talked about depression and substance use underlying suicide. So substance use is actually the second most frequent risk factor for suicide behind depression. So alcohol misuse or dependence increases risk tenfold, and 22% of deaths by suicide in the U.S. involve alcohol intoxication. And then once we kind of expand the issue to attempts, alcohol intoxication is involved in 30 to 40% of attempts. So what is under this connection between substance use and suicide? There's a disinhibition during intoxication. So a lot of times there are a lot of people that think about suicide that never actually make a plan or have any intent. So the disinhibition can kind of change things, and what is maybe socially acceptable might change, and then that increases risk of suicide or making a plan or taking action on a plan. There's increasing depressed mood. Alcohol also increases proximal risk, so it increases psychological distress, increases aggressiveness, it propels ideation into action, and constricts cognition. So when individuals do have alternative coping strategies, sometimes they're unable to bring those coping strategies to bear, and so they're unable to cope with the crisis that they're currently in. In 2016, SAMHSA put out a brief, Substance Use and Suicide, a Nexus Requiring a Public Health Approach. So this is a publication I'd recommend reading if you have the chance, and it talks about how substance use and suicide are related, and it talks about different ways that these issues can be addressed together, and how different agencies and organizations can collaborate in the process. So now to, I guess, the real the meat of this presentation. We're going to talk about screening, brief intervention, and referral to treatment, and then how suicide prevention can be integrated into this model. So I know that this webinar is based from an SBIRT group, and we have other people on this as well that are in the suicide prevention field. So I'm going to cover a little bit of information here on the what alcohol and drug use is looking like in the U.S. So you can see that there are, and so there's two different pictures here. One is 12 and older, so pretty much the general population, and then the figure on the right is youth, so age 12 to 20. And you can see that there are a significant number of users, binge alcohol users, and heavy alcohol users. Of course, those numbers get smaller as we go, but frankly, just taking a look at the heavy alcohol users, you can see that there are 16.3 million among the general population and 1.1 million among youth. And that if you're taking a look at youth, you see that there are a significant number of binge alcohol users, as could be kind of what we tend to think about and know among this population, that the as you're looking at the similar proportions, that the tan circle is pretty large and not too much smaller than the blue circle representing current alcohol users. And approximately half of the U.S. population, 12 and older, are current drinkers. Now, taking a look at drug use, we have 28.6 million people, or 10.6%, that report past month illicit drug use. So what drugs are being used? We see majority marijuana, and then we go down to misuse of prescription pain relievers, prescription tranquilizers, cocaine, stimulants, and so forth. And so we talk a bit, even though we're talking about an opioid epidemic, we have other drugs of use that we need to address as well. And 7.9% of adolescents 12 to 17 report illicit drug use in the past 30 days. So how is this problem being addressed? So historically, we talked about prevention. So this is preventing abstainers from initiating use. This is usually targeted to young people in school. We going way back, we talked about the DARE program. That there isn't really evidence to suggest its efficacy, but so this has been kind of what we look at as prevention. And then there's treatment. So for those with substance use disorders, with the goal of abstinence. Of course, there are people that drink alcohol, like recreationally, or people that are using drugs. And now, in the climate of the increasing legalization of recreational marijuana, there's going to be it's going to be more acceptable, and rates of marijuana use will increase. So there is a gray zone for people that are not drinking alcohol or using any form of drug, to those that need treatment. What do we do for these people? So most of these people don't have a substance use disorder, and of course they're not seeking treatment. So these individuals can benefit from early intervention outside of a treatment setting to reduce risky use before more severe problems occur. So we can look at this as a continuum, and we have abstinence and addiction, and then we have responsible use. This is the current model. You see that green, green circle, that's good, and then the red circle, not good. So we have prevention, and then we have treatment. Now I just want to break this up here with the second poll question as I begin the conversation about SBIRT. How familiar are you with SBIRT? And please select one of the following: not at all familiar, know a little bit about it and could use some more background, and very familiar. So just take a minute to complete this poll. Thank you. Great. Thank you, everyone, for completing the poll. That's very helpful for as I move this presentation along. Okay, so what is SBIRT? I'm going to give a little bit of information here as a background. So it's an evidence-based prevention and early intervention model to address the full continuum of substance use. So screening is done universally in a non-substance use disorder treatment setting. So we're talking about primary care settings, emergency departments, schools, school-based health centers, college health clinics, or mental health clinics, workplaces even. So this is done universally. It's not targeting people who come in and saying, well, this person has all these risk factors, I'm going to do a screening. So it's done for everyone as they enter this wherever they're getting the screening. And the screening, there are a few different screening tools that are recommended, like, for example, in the audit and DAST, which I'll talk briefly about, as well as for use, the CRAFT 2.0, as well as the S2BI. So these screenings are validated, standardized tools, and they're quick screens, and they provide a score and an algorithm as to how this individual should be treated and how the alcohol or drug use can be addressed. It's if an individual screens positive, a brief intervention is provided, and oftentimes a negative screen results in positive reinforcement. So the brief intervention provides uses motivational interviewing to identify pros and cons, what the issues are relating to the use, and how to in a patient-centered fashion, how to reduce use and prevent negative consequences in the future. If an individual scores at a certain level or deemed in the brief intervention that that an individual may have a substance use disorder, there is a referral to treatment, and that treatment is when a more detailed assessment will be conducted. So the goal of this is to identify at-risk substance users in a non-substance use disorder treatment setting and to provide appropriate services. So the idea here is that the individual is not seeking out services in a substance use disorder treatment setting. They're going somewhere else to receive services in a setting. So they're kind of not seeking it out, but instead, but they still are getting services. So I'm taking that. So taking a look at that continuum that we were just looking at, I'm going to now say this is what the SBIRT model does here. So we now have that same green circle. So it encompasses abstinence, experimental use, and social use. And then we have the red circle for those with substance use disorders. So that would be like a referral to treatment. And now we've got this area in the middle with the yellow circle encompasses binge use and problem use. So these are the individuals now that would benefit from SBIRT that were not actually getting any form of intervention before and could possibly have negative consequences or end up with a substance use disorder that later needs to be treated. So again, showing the pyramid here, we have three-quarters of the population are either at low risk or they're abstaining from use. So for them, no intervention or screening, no intervention is needed. And this would just be screening and providing feedback, again, like positive reinforcement. Then we have 5% that have a substance use disorder, and these individuals would get brief intervention and referral for additional services. And then there's that 20% of the population that normally would not have gotten any services, but with SBIRT were identified as having hazardous or harmful use or being symptomatic, and they would benefit from brief intervention or a more in-depth brief treatment, which is really like additional sessions of brief intervention, also being able to follow up and monitor with issues and identify any related co-occurring concerns such as mental health concerns. So now to integrate suicide prevention into the SBIRT model, there are actually a number of different parallels to this protocol, which I'm going to point out. And just first going to break this up again with another poll question. And so if you could just take a minute to complete this poll. Have you ever had a patient with suicidal thoughts or behaviors? No. Yes, one time. Yes, more than one. Or I don't see patients. Okay, here's the poll. So if you could just take a minute to complete that. Great. Thank you for responding to the poll. Okay, so I briefly talked about screening, and I mentioned the SBIRT screens, the audit, and the DAST. So the audit C is a pre-screen for alcohol use, 3 questions, and the DAST 1 is a 1-question pre-screener for drugs. So the way that that we would recommend inserting, trying to integrate suicide prevention into this protocol is by adding the PHQ-3. So this covers depression and suicide. So as I come from the SBIRT field, I was aware of the PHQ-9, which is a depression screen, as well as the PHQ-2. So if any SAMHSA grantees, SBIRT grantees out there, I was one in New York State. We were told to, it was recommended that we also use the PHQ-2 to screen for depression, and if there was a positive screen, to refer for mental health services. So when I entered the suicide prevention field, I got introduced to the PHQ-3, which includes those 2 PHQ-2 questions, as well as the last question of the PHQ-9, which is asking about suicide. So if there's a positive response to the suicide question, it could then trigger additional screening. So the screening forms, as I was just mentioning, so the full screening forms would be the audit, the DAS-10, and if we're talking about adolescents, the CRAFT 2.0 covers both alcohol and drugs, as well as the S2BI, and then the PHQ-9. So as I said, for the last, there's a yes response to the last question of the PHQ-3, or the same with the PHQ-9. Add the C-SSRS. So this is the Columbia Suicide Severity Rating Scale. It's also, not only is it referred to the C-SSRS, it's also referred to as the Columbia Screener. So if you hear any of those, this is a short screen. It's referring to the same thing, and this is a recommended screening for suicide risk. So the C-SSRS, as well as another screen I'm going to, it's Ask Suicide Safety Questions. this may these three can be used for these two can be used for adolescents. Um, so screen will be followed by an assessment version if necessary. So there is a C-SSRS assessment version. Now, so get into the details of what the screenings are. So the PHQ-3 is over the last 2 weeks. How often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And then the third question, the suicide question, is thoughts that you would be better off dead or of hurting yourself in some way. So if there's a positive response to that third question, it would trigger the C-SSRS or the ASQ. And just to kind of underscore that the importance of triggering another screen is that these screens, as you will see, are more specific and get into the level of risk. Because even this PHQ-3, you can see that it's a passive question. So thoughts you'd be better off dead or hurting yourself. It's a little bit more passive. So this is the C-SSRS. This I'm just highlighting again. It can be used for both adolescents and adults. This particular screenshot here was actually copied from a pocket card designated for adolescents. So it starts off with, have you wished you were dead or wished you could go to sleep and not wake up? So this is a passive question. And then question 2, have you actually had any thoughts about killing yourself? So you can see that's more of an active question. So if there's a yes to question 2, then you ask questions 3, 4, 5, and 6. If there's a no response, you go directly to question 6, and this is asking about any time of lifetime versus recent suicidal behavior. So have you done anything, started to do anything, or prepared to do anything to end your life? So question 3, have you thought about how you might do this? So if they answered yes to have you actually had any thoughts about killing yourself, have you thought about how you might do this? So this is really getting at the method. Do they have a method? Question 4 is, have you had any intention of acting on these thoughts of killing yourself, as opposed to you have the thoughts, but you definitely would not act on them? So this is intent. So this is really actually looking at intent without necessarily a method. And then question 5, have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So this is plan plus intent. Then again, you ask question 6, have you done anything, started to do anything, or prepared to do anything to end your life? This is questioning suicidal behavior, whether it's an actual behavior, preparatory behavior, or an aborted attempt. And you can see the color code here. The yellow is low risk, the orange is moderate risk, and the red coloring is high risk. So now, what does this mean? So having a wish to be dead or having suicidal thoughts would require a behavioral health referral. So this is not imminent risk. This is just there is some risk, and behavioral health referral to outpatient would benefit the patient and would be the best course of action. So question 3, suicidal thoughts with method without specific plan or intent. This would be a behavioral health consult, so with a psychiatric nurse or social worker, and consider patient safety precautions. Question 4 is suicidal intent without a specific plan. So this is similar, again, behavioral health consultation and patient safety precautions. This is we're getting into the high risk group here, and suicidal intent with specific plan, question 5, is the same. And then question 6, suicidal behavior but not within the past 3 months. And then question 6, again, suicidal behavior within the past 3 months. So something I want to underscore, and this is something that people in the suicide prevention field are aware of, and I will say I was not in this line of thinking before entering the field, is that what we try to do is treat the patient with the least restrictive setting. So patients, individuals, they want to stay in the community. And we, in the SBIRT field, talk about honesty and openness in reporting on a self-reported form. Sometimes it's face to face with a clinician or a provider, and are we honest? Uh, and as I was saying, patients don't want to be hospitalized, even if they're having thoughts of suicide. So if they express the thought of suicide and automatically get sent to the emergency department or get hospitalized, they're likely not going to report this, and then they, as a result, will not get the help that they need. So our goal is to keep them in the community, and there are ways to keep them safely in the community, even if they're having thoughts of suicide. So this is the Ask Suicide Screening Questions, the ASQ, which this is designed for use with adolescents, whereas the C-SSRS is designed for use with adults and adolescents. So this screen is, I'll go over this with you too. So in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? So as the provider, you would get information about how they had tried and when. And if the patient answers yes to any of the above, ask the following acuity questions. Are you having thoughts of killing yourself right now? And if yes, please describe. So what happens next? So if a patient answers no to all of the questions, the screening is complete. So you don't have to ask question 5. No intervention is necessary. But we always stress that clinical judgment can override the negative screen. If a patient answers yes to any of the questions 1 through 4 or refuses to answer, that's considered a positive screen. So you would go to question 5 to assess acuity. If there's a yes to question 5, that's an acute positive screen. That means that there's imminent risk, and that patient requires a be kept safe as well as provided a full mental health evaluation and cannot leave until they are evaluated for safety. So keep them in sight, remove all dangerous objects from the room, alert a physician or clinician responsible for care. If the answer is no to question 5, it's a non-acute positive screen. So there's risk, but it's not imminent risk. The patient requires a brief suicide safety assessment to determine if a full mental health evaluation is needed. So again, patients should not be leaving until they are evaluated for safety, and to alert a physician or clinician responsible for the patient's care. So now we always stress to provide resources to all patients. So there are, whether or not there's a positive screen. So there are some resources out there that can be used at any time. They're 24/7. The National Suicide Prevention Lifeline, that's 1-800-273-TALK. And there's also the crisis text line, which is particularly useful and used by young people, as their preferred method of speaking is by text. So an individual would text. There's actually a few different things that can be text to 741-741. Here it says text home. There's also text start to 741-741, and then you should check with your state and the suicide prevention individuals in your state, because a lot of states now have keywords that they use. And in New York State, it's got5. So if you're in New York State, you can text got5 to 741-741. And actually, what states are doing now with those keywords is actually being able to access a database to see who, where the texts are being made from, and what the issues are that are being discussed, and then demographics that actually help inform suicide prevention work, as well as other work with, namely like behavioral health and other social issues that texters are texting in for help for. So this helps to direct that work on the state level. So this text line is not only for individuals having thoughts of suicide, but it's also for use with depression, anxiety, relationship problems, substance use, domestic violence, and so forth. So this is, in addition, providers can also counsel individuals and those who screen negative on 2 specific changes or events that could quickly increase risk. So it's kind of planning ahead and identifying things that, if they do happen, the individual may start thinking about suicide. So going into the brief intervention. So briefly for SBIRT, we like to talk about the brief negotiated interview, or the BNI, developed out of Boston University. So the steps here are to build rapport, discuss pros and cons of alcohol and drug use, provide information and feedback. So you elicit information from the patient, provide information back, and then elicit their feedback, their thoughts on what information that you as a provider had just given them. And then using a readiness ruler to assess their readiness to make changes on a scale from 1 to 10 to reduce their alcohol or drug use, and then coming up with a patient centered and directed action plan for making changes. So there is also a brief intervention for patients who are at risk for suicide. We call that the safety planning intervention, or the SPI. So a lot of times when the safety plan is brought up, people just go to think about another form. It's just a plan and a form that gets filed away. And this is not completed on a piece of paper as an individual, but it's completed collaboratively, face to face, with a trained provider. So a provider will introduce the safety plan, and that pretty much talking about how suicidal crises come and go, and that a safety plan helps to prevent acting on suicidal feelings. And it also enhances self-efficacy and a sense of control among patients, because if they're able to, once they feel warning signs coming on, they're able to access this plan and able to mitigate the risk and to uh, stay in the community. They will feel that they have this sense of control, and it will improve their overall outcome. So patients, this is an evidence-based practice. So patients, in a recent study, patients who received the SPI as part of an emergency department visit for a suicide-related concern were half as likely to exhibit suicidal behavior and twice as likely to attend at least one outpatient mental health visit than the comparison group who did not receive the SPI. So the SPI has 6 steps, and they're progressive steps. And so the first is identifying warning signs. The second is internal coping strategies. The third is social contacts who may distract from the crisis. 4 is family members or friends who may offer help. 5, professionals and agencies to contact for help. And 6, making the environment safe. So I'm going to go through all of these steps and ways that this can be conducted with as a provider with a patient. So each individual has their own warning sign. So as a provider, you may want to ask, so what do you experience when you start to think about suicide or feel extremely depressed? How will you know when the safety plan should be used? So what you're after asking some of these questions, you're going to identify along with the patient a list of warning signs using the patient's own words. The next is our internal coping strategies. So these are ways that an individual can cope on his or her own. And so this could be like going for a walk, or walking the dog, or listening to music, or exercising, a number of things that can be done on one's own, reading a book. So what can you do on your own if you become suicidal again, to resist acting on your thoughts or urges? And then you also want to check in, how likely is it that you will do this in a time of crisis? And then it's also, if there's sometimes doubt will be expressed when you ask that, what might prevent you from doing these activities? Then as we go along on this step, as well as some of the subsequent steps, assess the likelihood that they will engage in the step, identify potential obstacles, and then problem solve. The next step is social contacts who may distract from the crisis. So just as we're going along, you see that each step that goes downwards, it's the first step to try. So an individual who's having thoughts of suicide and takes a look at their safety plan will first go to internal coping strategies and go for a walk. If that doesn't work, they go to the next step, and that's social contacts who may distract from the crisis. So this is not calling up a family member and saying, I'm feeling suicidal. I'm looking for help. It's someone that you know that can distract you completely, just to kind of get your mind off of things and make you feel better. So who may help you take your mind off problems at least for a little while? Who helps you feel better when you talk with them? This would be like going out and just socializing. So if that doesn't help, then the patient goes to the next step. That's family members or friends who may offer help. So this is really reaching out, say, to one of your good friends and saying, "I'm feeling suicidal. I need help." So among your family or friends, who do you think you could contact for help during a crisis? Who do you feel you can talk with when you're under stress? Now, if that doesn't work, there's number five, and this is professionals and agencies to contact for help. For help. So here you're going to develop a list, and that list is going to be handy for the patients. That's name, numbers, and/or locations of clinicians and local urgent care services. So you can ask, who are the mental health professionals that we should identify to be on your safety plan? Are there other healthcare providers? And then last is making the environment safe. So this is what we call restricting or reducing access to lethal means. So you want to know, do you own a firearm, such as a gun or rifle? What other means do you have access to and may use to attempt to kill yourself? And how can we go about developing a plan to limit your access to these means? This could be like giving a gun to away to a family member if you're feeling that you're having these thoughts of suicide. Have them store it for safekeeping in the meantime, or safe storage of medication. So we talked about, so SBIRT has the referral to treatment mechanism, and here suicide prevention we have follow up and monitoring. And there's one thing that is actually a structured phone follow up that's used in suicide prevention. So this occurs 24 to 48 hours after initial contact to provide support during a time of elevated risk. So, in suicide prevention, when the patient is being treated for suicidality, there are different risk points, and when someone is in receiving outpatient care, it's between appointments. Like, if is there a missed appointment, or that could be risk, or a patient that's not following up, and there's also when someone is discharged from an emergency department or a inpatient facility, the next 72 hours is the highest risk. So this follow up is extremely important. So there is a set schedule, as we say, for the follow up call. So assessing mood and current risk. So administering the C-SSRS. There's a since last visit version to determine level of risk, and to contact the crisis line if there is imminent risk detected. And then to review and revise the safety plan. So going over that safety plan we were just talking about to remove unhelpful items and to identify more helpful ones. And then reviewing access to means and whether there is a need to remove them. And then treatment engagement and motivation. So reviewing the treatment plan options and problem solve obstacles to treatment, and providing, again, information on available community supports, including the Lifeline and Crisis Text Line. And then ensuring obtaining consent and willingness for additional follow-up. So are there do further calls need to be made? Does it seem like the patient is going to be resistant and not want to follow up via the phone, and problem solve that and see if you can get more interest and willingness to talk on the phone in future attempts? Set a call time. That could be helpful to actually get the person on the phone, and then let the client know how to initiate future care. There are also other ways of following up, and one of them is non-demand caring contact. So this is like postcards, letters, emails, texts. It shows that someone cares. Um, there's been study on this that shows, and this is a very inexpensive method to reduce suicide, as research has shown that patients who refused further care but received these contacts had a lower suicide rate than those in the comparison group who did not receive these contacts. And so there's, as I was saying, there's a variety of number of ways to send these care and contacts out. And I was just recently talking about that youth now like texting. That's like a preferred method of communication. That this can actually be done through via text message with youth. And then we have warm handoff to other levels of care and suicide specific treatment. So this is like the referral to treatment in the SBIRT model. And so there's a few different suicide specific treatments, including cognitive behavioral therapy for suicide prevention, dialectical behavioral therapy or DBT, and collaborative assessment and management of suicidality. So as we know in the SBIRT world, and we actually know in the mental health world too, that individuals don't always follow up on referrals and end up connecting into treatment. So the same thing is very likely to happen with individuals who are at risk of suicide. So the idea of having the screening and the safety planning intervention, as well as the follow-up phone call, all of these things are services that get provided and tools that an individual at risk has, and they don't follow up with the referral. They do have these things in hand. So we want to make sure that all of these, as many of these needed interventions and treatment occur, but we understand that they don't always get them because patients don't always access them or follow through. So each part of this is important. We want the patient to have some form of intervention when necessary. So because we have this is an adolescent specific forum, I did want to stress kind of what can happen on the school level. And I know it's coming from the SBIRT field that individuals that states and localities are interested in implementing SBIRT in schools because youth spend a lot of time, most of their time in schools. So there's a lot of work being done for suicide prevention in schools, and there are some trainings available. I just wanted to point your attention to. One of them is helping students at risk for suicide. So this provides clinical training to school personnel that are typically clinical providers in the school. Trains on the C-SSRS screening and assessment, as well as the safety Stanley Brown safety plan. So that is, if I didn't refer to it already, that is the safety planning intervention that I've been talking about, and it's developed by Stanley Brown. There are other safety plans out there, but this is the one that's recommended for suicide prevention. So you may hear it referred to as Stanley Brown. Another training is actually developed by my colleague at the Suicide Prevention Center of New York is creating suicide safety in schools. So this is a little different in that it's a full day workshop, and it's assisting schools in developing policies and procedures for suicide prevention. So that includes these clinical tools that I've been talking about, including the C-SSRS, the brief intervention using the Stanley Brown safety plan. But it also talks about communication between the schools and mental health providers and using different school personnel and identifying risk and referral. So it provides it's a larger workshop that is also involves administrators and psychologists and teachers and whoever would attend to develop policies and procedures for the school. And then the companion was all training was also developed by my colleague called Suicide Safety for Teachers, and this is a 1-hour awareness training to help teachers identify students at risk. So this we know that teachers don't have kind of a huge burden in this in the role of treating patients who are students who are at risk for suicide, but they do have a key role, and that is because they spend a lot of time with these students on a daily basis and can definitely identify any changes in behavior or any warning signs, and then get them to the appropriate service. And youth, in particular, are interested in using apps, and apps are becoming more and more popular among the entire population. So there are a few apps here. I put two on the screen here that are suicide prevention apps. The first one is My3. You can see the left image of My3 shows my safety plan. So this is actually the safety plan we just discussed, and an individual can put a safety plan right in here to access on the phone. So when warning signs start coming up, they can just access it right on their phone. We all now tend to have our phones on us all the time. My three refers to your top three people that you want to contact, so you list my three in there. And it also provides spaces for resources that you can go to anytime. You can see on the screen here for veterans, for LGBTQ youth, local suicide prevention activities, for warning signs, and so forth. The other image is the Stanley Brown Safety Plan. So they have an app developed specifically for this safety plan that, once again, you can put in the specific information. Actually, a provider who's developing the safety plan with the patient can then, if they, while they're in the meeting, have the treatment session to actually put this information in their app. And then on the right image is this information about the safety plan. So you actually have that on hand about what each step is and what a safety plan is and who should have one. Okay, so this concludes the my portion of the presentation, and I want to thank everyone for listening, and I want to thank NORC for inviting me to deliver this presentation, and I'm going to hand it back over to Dr. McPherson.
Thank you, Dr. Harris. I appreciate that, and what wonderful, what wonderful content. So I am looking forward to again working with you more in the future to bring more information around suicide prevention into the SBIRT model. And we just want to thank you so much for your expertise and encourage everyone to share this information about this webinar. And please look out for other webinars in our series on this topic, such important information. And we are grateful to have your knowledge shared with us today. So thank you so much. In our last couple of minutes, I want just to remind folks that the PowerPoints are already up and available, and you can share those also with your colleagues. And I would encourage you to visit the sbirt.webs.com website and look at the webinar page dedicated to this webinar. Any additional materials related to the content would be housed on that page, and you'd be able to download those directly from there as well. After the webinar concludes, you're going to receive a follow-up email from us that contains instructions for watching the on-demand recording, obtaining a free certificate of attendance, and completing, again, that short evaluation survey, which we urge you to complete to really help inform the important work that we're doing with the Conrad Hilton Foundation. In the last couple of minutes, I would like to share with you some information that I think you'll be interested in learning about some of the things that are coming up with the expansion of our Learner's Guide to Adolescent SBIRT curriculum. If you're not familiar with it, we have developed, with funding from the Conrad Hilton Foundation, a full curriculum or training kit for you. So whether you are a person who trains other members of your organization, or you are an educator and you're training students, preceptors, field instructors, other educators, this curriculum is really designed to help you deliver that education and that training. And this guide is free electronically and available to everyone. You can request a copy of the curriculum here at the sbirt.webs.com website. You can click on the curriculum tab, and you will see a full list of all the information and resources contained in the curriculum and in the toolkit. On that page, you're also going to see information about the SBI with Adolescent online simulation training. So the curriculum has two pieces. It has the instructor's guide, the learner's guide. It has all of the companion PowerPoints that go with it, and I'll talk about that in a minute. But also complementing the education and training in the curriculum is an online simulation-based training. If you're interested in learning more about SBI with adolescents, you can download the flyer or review the flyer, learn more about the objectives, the learning objectives of the simulation training, learn more about the features, the continuing education credits that are offered with it, and learn more about the scenarios. There are 3 scenarios in the simulation, and as a competency-based training, at the end is a competency-based assessment built in. And so you can learn a lot more of that, about that, on our website. You can also watch a trailer or take a demo of the simulation by going to the cognito.com website. There you can click on products, and you're going to see a number of products, including SBI with adolescents, and you're going to see a button that says watch trailer or take demo. While you're there, I would encourage you to take a look at some of the other simulations focused on substance use and mental health, working with adolescents, young adults, and adults, and also look at some of the other simulations that are available that include education and training around suicide prevention and post-traumatic stress disorder and other topics. So I want to orient you to that, but also let you know that as part of our Conrad Helton Foundation work, we have a number of opportunities to engage with the SBIRT team and be able to utilize and access SBI with adolescents. So if you're interested in learning more about those opportunities, I would encourage you just to send an email to the SBIRT team at norc.org, or you can certainly kind of peruse the website sbirt.webs.com to learn more. So just to give you kind of a high-level overview of the Learner's Guide curriculum content, the training content, the guide is a comprehensive introduction to screening and brief intervention and referral to treatment for adolescents and young adults. It includes all the components that you would need to train others around screening and brief intervention, and it has modules specifically on motivational interviewing skills that are taught to help individuals facilitate screening and brief intervention and referral to treatment conversations. And so each module includes a comprehensive content that you can provide to your learners. But in addition to that, it is structured so that it provides you specific learning objectives for each of the modules. There'll be suggested readings for each of the modules. And we also include sample conversations or sample interactions with dialogue that can be used as part of practice sessions. They can be used in role play activities. They could be used as part of kind of a standardized patient scenario. And then in addition to that, we also have role play activities that allow some dyad and triad kinds of training and learning activities. You can use this, again, as part of educating students or training other professionals. You can also use it kind of as a pace learning, your own self-paced learning, or for others can use it as their own learning at their own pace. So again, a copy electronically is available at no charge. There's also an order form on the website for a printed copy, which we make available for the cost of printing and shipping only. In addition, on our website, there's a whole host of companion training, learning, education materials that are available to you. So we have, even statements from leading professional associations or policy guidance or position statements around adolescent screening and brief intervention. So we have those kinds of materials that kind of help to for you to sort of learn about the literature around screening and brief intervention for adolescents, but also to be able to help you find your own talking points, your own if you're trying to convey information about the importance of this, making sort of the clinical case for it, it really can help you to inform your own thinking and your own position about, bringing it to get the buy-in that you need if you're interested in educating or training other folks, or you're wanting to put this into practice. That kind of material is here to really help you form your own talking points. In addition to that, we have resource lists specific to other materials that are out there. There could be an online course that's available that offers CEs, many of which are publicly available. They're free or low cost because the CEs being offered. So there are lots of resources there. There are also some other information about other substances, specifically as we see more being used, more information coming out about, for example, vaping with adolescents. You're going to see more and more resources posted around some of the other substances that are getting more attention, but you're also going to see resources and links to literature on substances, marijuana, and alcohol, which are primarily the two most common substances. You're going to see more information and resources specific to those. And forthcoming, we're going to see more posted here around working with adolescents around opioid use. So we encourage you to visit the resources, check back, see what else is being made available to you, and also look for new tools, new screening tools. So I hope you will attend the webinar that we are doing on adolescent screening tools, and you will see a lot of the tools that are discussed in that webinar we're going to be making available in the resources section. So they're very easily downloaded, quick access points for you. And in addition to that, we've had our partners that we work with as part of this initiative to help bring you examples of evaluation tools that you might want to use to evaluate whether you're educating or training others, or maybe they're evaluation tools looking at fidelity and quality of conducting a brief intervention. Whole host of tools that you may not be familiar with that could really be useful in the work that you're doing. We'll also bring you, and already up there, our webinars from our partners and other other organizations who've been really doing a lot of good work in this area. We want to make sure we're sharing theirs. So, of course, we welcome all of you. If you have materials that you think would be very useful to, the kinds of folks that attend our webinars like yourself, we are glad to help, put those and make those available on our website. So as we think about the content today that we've heard from Dr. Harris around suicide prevention, as we integrate more materials into the learner's guide and into the companion slide decks, we're going to be putting the tools that we were talking about today and others around suicide prevention up in this place as well. So this is going to be a growing area, both within the curriculum and the electronic formats of the learner's guide, as well as here. So this is a great resource for you to bookmark. And in case you'd like to, share a link with your colleagues to an overview of the Adolescent SBIRT toolkit that we've created in collaboration with IRETA, we have put together an on-demand learning that will walk through the curriculum in more detail. So this will give you a chance, if you want to refresh, share it with other folks to really learn more about it. We really encourage you to do that, and from there you'll also be able to link to order a copy. So in closing, I just would like to offer folks an opportunity. If you have questions about screening and brief intervention, you're implementing education and training, you're implementing SBIRT practice, you're wanting to evaluate what you're implementing, or you're interested in training resources even beyond the ones that I've mentioned, or being connected with a motivational interviewing trainer, a trainer who focuses specifically on screening and brief intervention with adolescents, or a combination of adolescents and young adults and adults, I'd encourage you to send me an email. If you're looking for some telephonic technical assistance, you want to have a quick call about something, you're really thinking about a particular aspect of your training or your evaluation, or you're exploring the kinds of research questions that you're trying to ask in your work, I just would like to be able to offer, some technical assistance that we can provide by email, telephone, and you've got my email address here, mcpherson-tracy@norc.org. You can also contact the SBIRT team at norc.org at any time as well. So in closing, I want to thank all of you for attending, and I also want to say a huge thank you to the Conrad Hilton Foundation, who sponsored this webinar, all of the webinars in our series, and all of the wonderful work that we're doing with educators and practitioners in the field who are serving adolescents or training the next workforce. This is certainly a collaborative effort. Our partners, CSWE, AACN, Cognito, and others have been really instrumental in bringing this kind of education and this kind of initiative as a national workforce development initiative together. And so we thank everyone, and we invite all of you in to learn more about our work and to take advantage of this the webinar series and the resources that we have by visiting sbirt.webs.com or contacting our team. So thank you, everyone. I thank you for participating in this webinar, and thank you, Dr. Harris, for this fantastic education that you've given us today. And we're looking forward to more from you and working with you in the future.